There she is. Okay. No, I waited for you. I knew you were coming.
Yeah. Yeah. I love that. Celsius.
From who?
Yeah.
On fire. Sorry, is it your stomach? No. No, I'm not. It's your stomach, right? It did not. Yeah, we were like figured child on fire. It was like so spreading.
Okay, I think we're ready. Thank you guys all for being here. I'm really excited to give this presentation for pediatric surgery review for the ABSITE. These slides were adapted from Dr. Connor Chick, who we all love. No, they have been edited, but thank you, Dr. Navarro. Okay, so the big thing that we obviously have to talk about is emesis. I think that this comes up, all the time, and also is just very important for our, for just learning and taking care of kids in general, because kids puke a lot. And so the big differentiator is if it's bilious or non-bilious. So, Katie Bug, what determines whether or not the vomiting is going to be bilious?
It's like your post.
If what is?
Obstruction.
Yeah, so depending on where the obstruction is in its relation to the ampulla and whether or not bile can get into it. So if you think about it like that, then I think that you can kind of work through most of the questions, because I think a lot of the questions, especially if the question stem is bilious emesis, sometimes the answers, there will only be one choice that could even cause bilious emesis. So that can be your starting point. And so if we think about things that could cause bilious emesis, obviously the thing that we are on high alert for is the malrotation with midgut volvulus. Okay, so Kate, yeah, there's not a lot of pictures, sorry. So Katie Bug again. So tell me what midgut volvulus is.
It's like rotation.
Right. And what is it about the malrotation that predisposes to midgut volvulus?
Like the air connections with lab bands.
So that's what a lot of people think, and I think that I always thought of it like that too. And that's because the procedure that we do is we go in and we cut those lads bands. Does anyone know? No, so it's actually, it has to do with the mesentery and like the narrow base of the mesentery. And so, as we all know, embryologically, we have this, our intestines come outside of the abdomen, and then they're supposed to go back in and rotate correctly, and then they get affixed in the right orientation. And if that doesn't happen, then we are malrotated. But the reason that that's so prone to twisting is really because that mesentery is very narrow. And so you go in and you cut all the lads bands and you try to put things back the way that they're supposed to be, and you hope that it scars in correctly. But if you have like a particularly narrow base, then they can still have, complications from being malrotated. And so, for questions and test taking, you just have to be on high alert for that, because if there's any kid who's having bilious emesis and has any sign that they're sick, then you're going to want to get them to the operating room, because this can obviously be a devastating complication. And then I already have up there on the slide what the imaging study is. So you'd get an upper GI. And does anyone want to describe what you should see on the upper GI in a normally rotated intestine? Flynn. Yeah, go ahead.
I contrast.
Yeah, that is very true. There's,
I thought you were. talking
no,
about
an upper GI, a swallow. Yeah, that's okay.
that makes sense.
Yeah, so in a normally rotated kid, you should see the, the contrast crossing midline. And then you also on a lateral view, you should see it go all the way posterior, like to the spine, essentially like to right in front of the spine. And that's how, you're seeing it go back to where the LOT comes out. And that's how you know that you have normal rotation. And if you don't see that, that's concerning for Malro. And then we already talked about the LADS procedure. And then something that I've seen on practice questions and that behind the knife always talks about is doing an appy at the time of your LADS procedure, which we do. I mean, in peds a lot, just for other belly cases too, to avoid diagnostic uncertainty. Exactly. Large on the left, large on the left. So you do your counterclockwise rotation and then you put the large bowel on the left and the small bowel on the right. And then you're hoping that everything scars in. And then they'll often ask questions about meconium ileus. So meconium ileus or a meconium plug is obviously a very distal obstruction, so it can also cause bilious emesis. And we all know that there's a relationship to cystic fibrosis with meconium ileus. What else can present with failure to pass meconium within the first 24 hours of life? Hirschsprung's, excellent. And how do we diagnose Hirschsprung's? A suction rectal biopsy, excellent. Often before we do a suction rectal biopsy, we'll get imaging for Hirschsprung's, right? So what imaging do we get if we suspect that a patient may have Hirschsprung's? A contrast enema, good. Excellent. Dr. Flynn is telling us about the rectosigmoid ratio. That's telling us that that this patient might have Hirschsprung's. And so in a Hirschsprung's baby, you're going to see that the sigmoid is really big relative to a very small rectum. And so that is indicative of Hirschsprung's, and then you confirm with a suction rectal biopsy. And then what is the treatment for Hirschsprung's disease? Good. So you do a pull through. Does everyone remember the names of the different kinds of pull throughs? So there's the Suave. I actually don't think I have these written down. The Suave, and then anyone remember the other ones? The Swenson. So I don't think that they actually usually ask these on the exam. Has anyone seen pictures of these? The pictures, I should have put some pictures in of these. But the pictures are really helpful to understand. Can anyone describe the Suave procedure for me? Pranav, we're talking about Hirschsprung's disease. We're talking about pull-throughs, different kinds of pull-throughs. Do you know what the Suave, I always call it the Suave. Is that how you pronounce that? Okay, so what is the Suave procedure? It is a good question, isn't it?
When I was on PT.
I feel like Google's failing me right now, that in my mind's eye, it's like a mucosal, like just the mucosa gets pulled down. So it's like this. Like you actually.
Exactly. The Suave, oh, I hope that that's still sharing. Exactly. So the Suave is the one where you leave that aganglionic cuff. And so you do the mucosal dissection, and then you're bringing that, well, sorry, it's not a mucosal dissection. Very, very importantly, it's not. What layer is really important to us in Hirschsprung's disease? The submucosa, because the submucosa is where the ganglion cells are, right? And so very importantly, it's that submucosal dissection. And so you're bringing down the mucosa and submucosa, and then you're leaving that aganglionic cuff behind. I actually think that you bring the muscularis down too, actually. But I'll include some pictures when I send out the slides so that it's easier to understand. And then the Swenson is like our traditional pull through that I have seen done here, where you are actually doing, you're doing as much of the dissection in the belly as you can laparoscopically, and you're mobilizing the entire rectum. And then you do a perineal dissection around, the entire rectum, and you pull that entire rectum through. And so you're not leaving a muscular cuff, and then you're doing a coloanal anastomosis. And so that's the Swenson. And then does anyone know what the Duhamel is? So yes, yes. So you are basically doing a you're like stapling above where you have the ganglion cells, and then you're bringing that ganglionic piece down, and you're doing an anastomosis between the aganglionic and the ganglionic, and you're joining those two up. Does that make sense? That's the Duhamel. Okay, those are Hirschsprungs. I don't know. I don't know if I've ever had a question about the actual procedures, but that can kind of sometimes help remember things, I guess, if you think about it clinically. Okay, so, and then obviously neck can also cause bilious emesis depending on where your complications from neck are happening. What's the more common presentation of neck? How are you going to see a neck question on the test? Yeah, perfect. Yep, and there's one more finding that they'll sometimes talk about with neck. Bloody stool, yeah. So Dr. Navarro was telling us about a newborn, usually premature infant, who after the first feed has increased abdominal tension, maybe emesis, and difficult to assess for nausea in a premature baby, I would say, but certainly emesis, right? And then Dr. Navarro pointed out the breastfeeding thing, which often people will talk about, non-breastfeeding babies being at higher risk for the development of neck. It also kind of in real life, I think, complicates the picture a little bit because you can be dealing with milk protein allergies and allergies to certain kinds of formula and things like that. But on the test, I think that's a good summary. And so what if, I think that where bilious emesis comes in, I mean, obviously you can have bilious emesis just with your initial presentation of neck, but also sometimes a neck baby then down the line, recovers from their neck, didn't need surgery for it, and then presents with bilious emesis. And what's your concern there? Stricture. Yeah, good. Oh yeah, we have annular pancreas up here too. So, what is the babygram finding that you'll see with a lot of times both duodenal atresia and like annular pancreas? The double bubble sign, yeah. So, the annular pancreas is associated with Downs, yes, and duodenal atresia, yeah. I think, yeah. Okay. I think we talked about everything on here. Obviously, colonic atresia can cause bilious emesis, and then imperforate anus. You should always make sure that the patients have a butthole. That's very important. Okay, so now we'll talk about non-bilious emesis. What's like the thing that you're going to get tested on for non-bilious emesis? What's the thing that pyloric stenosis? Yeah, they love talking about pyloric stenosis. Oh yeah, here you go. Duodenal atresia or Webb Down syndrome. I forgot to put that on there. Okay. So pyloric stenosis, you're going to have a baby who has projectile non-bilious emesis, and then they have this rule of fours. So I like to think the pi thing, pyloric stenosis 3.14, because Pi Day is my birthday. And so it's very easy for me to remember 3.14. And now you guys will all think pyloric stenosis, Meg's birthday, which you all already know, 3.14. So you guys will do fine with this part. So what is the most important thing you have to do when you get a pyloric stenosis baby? Resuscitate, good. And what's the people at home think that you can see it right now, but you can't, so this is perfect. Perfect. Hypochloremic, hypokalemic, metabolic alkalosis with paradoxic aciduria. Why do you get paradoxic aciduria, Katie Bug?
Well, you're losing acid when you're trying to restore sodium.
So it's kind of the other way around. So think of it like, I always think of it like this, and this is going to sound like obviously like the dumbest version of everything that you've ever learned, but I always think about like that you're alkalotic, right? And so it's paradoxic because you're alkalotic. So you should be trying to hold on to your sodium, but you have to exchange it. I think it's for the sodium.
That's sodium.
Chloride. So you're trying to, like,
Exchanger and
replenish
just chloride.
chloride.
It's the chloride. Yeah.
Yeah.
So you're trying to hold on.
Taking chloride. Yeah.
It's the sodium bicarb exchanger though. So you're right, Katie Bug. It's the sodium bicarb exchanger. And so you are trying to hold on to the chloride. And so then you're peeing out those acid, the hydrogens. Does that make sense? I don't know if I said it correctly, but that's why it's paradoxic aciduria. So you want to resuscitate first. What are you going to resuscitate with? Perfect. And then after the patient is adequately resuscitated, then you can start a maintenance IV fluid with dextrose. You want to be careful with the dextrose and obviously big shifts in fluids that can happen with that. And then pyloromyotomy, sometimes they'll ask about this. So like how you know if you have a complete pyloromyotomy. Yeah, you should see the bulging of the mucosa underneath, and then you should be able to like move the muscle that you just cut independent of that. So it should be completely separate from that mucosa underneath. And then if you mess up on the gastric side of things, how will you mess up? Yeah, not going far enough. If you mess up on the duodenal side of things, how will you mess up? Perforation. So just think about it like the stomach. It's harder to perforate the stomach. It's easier to perforate the duodenum. But it's easy to leave behind too much muscle on the stomach side of things. I don't know if they'll ask that, but they talk about it on Behind the Knife. So, anything else about pyloric stenosis that I missed? I always thought it was it depends on their age. Usually I think with these babies, because they're 4 months old, I think you usually do D5 half, if I'm not mistaken. But that would be something I'd have to look up. I don't know that for sure. So don't just look that up and get back to us. Sorry, I don't know why this is not coming up. I'll send them to you. Okay, so let's talk about gastroschisis versus omphalocele. So what's gastroschisis, Joe?
When you don't have, usually a result of an ischemic insult in utero.
Good.
So basically,
Yeah, so you have exactly, uterine vascular accident, and you don't have a formation of the abdominal wall, and you don't have, what's important in this as well is that you don't have like the appropriate rotation back into the abdomen because the abdominal wall doesn't exist. And so for this one, is it going to be located directly through the midline or to the side of the umbilical cord? To the right side. Good. Gastroschisis is to the right side of the umbilical cord and it's not covered by a sac. So omphalocele, I always think about like the sac being the umbilical cord because it kind of looks like that too, like that stretched out kind of like slimy stuff. And so it's right in the middle and then for gastroschisis, you still have that umbilical cord and it's just all of the intestines are sitting to the right of that umbilical cord. And we already talked about that it's due to a vascular accident. So what other things are associated with gastroschisis? Yeah, other atresias. So you have to, when you do surgery to put this back, you have to make sure you run the bowel and look for other atresias elsewhere. And then what is the treatment for gastroschisis? What do you do? Yeah, you put it back in. So Trappy does a sutureless closure sometimes if the defect is small enough. Obviously, we heard Dr. Thomas's feelings about that. He does not do sutureless closures. He, take him to the OR and do a formal closure of the abdominal wall. But I don't think that they'll differentiate between that. I think it's just about like getting the patient, the initial management, you put like something wet over it. They still test about that. Dr. Thomas was like saying that, don't tell the outside hospitals to do that when he gave his lecture, but they'll still test on that, put something wet over it. And then, you want to bring them to the operating room and close the abdominal wall as quickly as you can. And what if you can't? What if you don't have enough abdominal domain to close the abdominal wall? Right, you can use a silo. And so you can put on at the bedside or you can put them on in the operating room. Sometimes they'll sew them to the edge of the abdominal wall and sometimes they're sutureless, but it just depends. And so sometimes they do test about a silo. Is a vaginal delivery contraindicated in gastroschisis? Right? Fun. Joe, you like deliveries?
Gastroschisis, yes, but I'm not.
Is a vaginal delivery contraindicated?
No.
Gastroschisis-
Correct. In gastroschisis, it is not. You can, you're not gonna mess anything up. You can have a vaginal delivery.
Vaginal birth. Like an eviscerate baby, like a whole baby.
Believe me, guys, I'm with you. But, yeah. I don't know why this isn't working. It was working.
I might as well liquid come out of your mouth on that.
Okay, so then on omphalocele, sorry, you guys can't see the slides, but it's better this way because it's more like you guys don't know the answers yet. And I do, so I'm like, yes, I knew all of this, which I really should. Okay, so omphalocele is a midline defect, like we already said. What is omphalocele associated with? Yeah, so there's a couple of trisomies that it's associated with. And then you can also have hernias, congenital diaphragmatic hernias are associated with omphalocele too. What else were you saying? Yes, cardiac anomalies too. Like an endocardial cushion is one that Dr. Chick mentions in this, but cardiac defects in general. Covered with a sac. And then this is the one where you would want to do a C-section. I have to look up why that is. Oh, because you don't want to rupture the sac. Yeah, rupturing the sac is, complicates everything. And so because the sac is intact, with gastroschisis, there is nothing to rupture. You're not gonna rupture the intestines. What does a giant omphalocele contain, Katie Bug?
It's about, but it can also contain other organs.
Yeah, so if they say giant, they're saying liver usually.
We could Google AI, that way. 5% dextrose being 0.45%.
Per kid,
Yeah,
per
half-
kid, yeah,
half-
also 5%.
Half normal. Yeah, that's what we said. Okay, cool. Okay, wonderful. I think it's when you get. Yeah. When you resuscitate for pyloric stenosis, you resuscitate with normal saline, and then for maintenance fluid, you switch to D5 half normal.
Yeah, I think there used to be a thought that for like, you need to do by quarter normal, and I think that is now falling out of favor.
Dr. Carpenter is saying that, sorry, Dr. Barbera, my one true love, Elizabeth, is saying that, going back to the pyloric stenosis, we resuscitate with normal saline and then maintenance fluid with D5 half normal, and there used to be, we used to talk about doing D5 quarter normal for preemies, but that seems to be falling out of favor, we believe. Okay. Tracheoesophageal fistula. This is one where we really need the pictures, like, why is this not working? Maybe it's coming. Yeah, Pranav, why don't you go draw the different types of tracheoesophageal fistulas on the whiteboard then? What's the most common type of tracheoesophageal fistula? Yeah, and what is type C?
The distal.
Exactly. Esophageal atresia with a distal TE fistula. And so what will that look like on your babygram? If you have a babygram and you have your trachea connected to your stomach. Yeah, so you'll have air distally, which is different from, like type A or B where there's no distal fistulization. Type A is the one where there's just the esophageal atresia and then there's no fistulization distally. So like, it's not really a tracheoesophageal fistula, you know what I mean? That's kind of like, always has annoyed me, but, and then type B is the proximal fistulization. So it's the esophagus fistulizing to the tracheo bronchial tree. And then the other ones will all have gas in the abdomen. What is the presentation? Like, how are they going to lead you to a TE fistula in a baby? Yeah. Yep. So PO intolerance, drooling, respiratory distress, and inability to pass an NG tube into the stomach. Or yeah, a revocal, which is an NG tube. What associated anomalies do you have to worry about? Good. And so what does VACTRL stand for? Limb anomalies. Yeah, good. Katie Bug did it so well. Vertebral anomaly, anorectal malformation, cardiac defects, tracheoesophageal fistula, renal, yes, TE. Renal, and then limb anomalies. You guys know what I mean. So so you're gonna do obviously a good physical, like make sure that they have like all their limbs and stuff, and then and then an echo, a babygram, and a renal ultrasound. Okay, how are we doing?
Normal.
Yeah.
Write this one down.
Just in case,
Yeah, I know, that was.
Okay, like, and so this one doesn't have an esophagus. This is a, good one for them to just give you an X-ray and like a presentation of a, like baby, so, I think I used to think that the test that is.
Dr. Barbera is saying that, this is one where they're likely to give you a babygram and just like a presentation. And that, yeah, and we used to think that this was too specific to learn, and I agree with that. But, but, you know, sometimes they do, but you know, like one question, you know what I mean? Those questions do add up. Okay.
Oh my.
Yeah, definitely. Okay, I put some slides in about pediatric trauma. I don't really know if I've ever actually gotten a question about the ET tube size. They always talk about this, like behind the knife and stuff. Yeah, age over 4+4, but yeah, in real life, you're gonna either use their pinky finger or Breslov tape, right? I have seen questions about, cuffed and uncuffed tubes, right? So who are you not allowed to use a cuffed ET tube in? Premature babies, like really small babies. That has changed. They used to say that you couldn't use it in babies at all, but, and why? Subglottic stenosis, yeah, which, you know, it, yeah, yeah, so I would say that unless they're like emphasizing that the baby's really small and premature and stuff, I would say to choose a cuffed ET tube. And then behind the knife always goes into like how to bolus a patient with fluid and how to transfuse pediatric patients with blood. Does someone want to talk about that? Excellent. Pranav saying 20 cc's per kg for crystalloid and then 10 cc's per kg for blood. Dr. Chick has a bullet point on here about a needle cricothyroidotomy and jet ventilation in infants, which I think is really cool. I haven't seen a question about that before, but, and then we all know how to handle solid organ injuries. We're experts, really, at this institution. We love non-operative trauma. So what, they might ask you the handlebar injury. What are you worried about? Yeah, duodenal hematoma, which you manage non-operatively. Okay, and then we have a slide on here about pediatric cancers as well. So, the BTK talks about the classic presentation of this cancer where, you know, you're giving baby a bath and you note an abdominal mass. And then you might also notice the raccoon eyes. People talk about raccoon eyes. What is the neuroblastoma, right? And so the metastatic disease is what results in that raccoon eyes. And then what's the treatment? So if they're less than 18 months old and oligometastatic, they will often regress spontaneously. Neuroblastomas. That's what we have written on this slide here. If less than 18 months old and oligometastatic, regress spontaneously. If resection is low risk, like obviously beyond 18 months old, then you're gonna resect right off the bat, surgery first. But if it's a very high risk resection, then you can do induction chemotherapy. Do you guys know the amplification that portends a worse prognosis with neuroblastoma? Yeah, and Nick. Yeah. Connor, also put it as Mick N, but I've always heard N Mick, right? N dash Mick. Okay. And then Wilms tumor, what's a Wilms tumor? Good. And so how are you gonna tell the difference between a neuroblastoma that's originating like in the sympathetic train near the adrenal glands versus a Wilms tumor? Right. So how will that look? Exactly. Yeah, exactly. So neuroblastoma, you'll see displacement of the kidney, and the Wilms tumor, you'll see replacement of the parenchyma of the kidney. And then what do you do for a Wilms tumor? Take it out. Do you biopsy it first? No, that's the big thing, right? And why is that? Exactly. And so the big thing for Wilms is that you don't want to rupture it because that upstages it. And so if you biopsy it, then you're automatically spreading that along the biopsy tract and rupturing it. So you don't want to biopsy. It has a characteristic appearance on imaging. And then hepatoblastoma, what are you going to see in this question stem that leads you down the hepatoblastoma route? Yeah, increased in AFP. And then what's the treatment for hepatoblastoma? Take it out. Yes. So surgery unless it's widely metastatic. And then if it's, if you're going to jeopardize your future liver remnant by resection and it's only confined to the liver, then you can consider transplant. Okay. Phew. Now we get to talk about the fun stuff. Peds thoracic, which actually I do feel like we get a couple questions about peds thoracic. Yes. I don't know the answer to that. Pranav is very astutely asking about the future liver remnant for children. I'm not sure if it's the same, so you will have to once again look that up and get back to you. It's a good question, but I'm not sure, so I don't wanna try to answer. What's the most common mediastinal mass in peds? First, let's go back. We talked about during the thoracic, the most common mediastinal mass is in adults, right? So what is the most common mediastinal mass overall in adults? No, in adults. The most common mediastinal mass overall is the posterior one, neurogenic, right? And so that's because even though anterior masses are more common, there's all different kinds of anterior masses, right? And so cumulatively, it's still more common to have a posterior, like a neurogenic mediastinal mass. Does that make sense? And so in adults, what's the most common anterior mediastinal mass? Thymoma. Yeah. Yes. So in peds, the most common overall mediastinal mass is still neurogenic. That's still true. That's posterior. Yeah, because of the spine, the neurons, spine. And so what is the most common anterior mediastinal mass in kids? Teratoma. Good. Okay. What's the most common malignant mediastinal mass in kids? Yeah. I think. I didn't write that one down. I'm gonna have to check again. If I say stuff that's wrong, I'll like text you guys about it after this. But... Oh, I don't edit. I can't. Yeah. What you see is what you get.
Not just a presentation.
Yeah. Okay. So talk to me about pulmonary sequestration. That's something else. Good. It's separate from CPAMs. Uh-huh. Good. So it's lung tissue.
Yeah,
Good.
yeah.
Joe and Katie Bugger are doing a really good job for those of you at home. And Ashley Flynn Patterson.
Wow.
So pulmonary sequestration is lung tissue that is not connected to the bronchial tree
Yeah.
that has its own blood supply. Why is that a problem? It's taking up space. That's a big problem, right? So there's not enough room. So you're not oxygenating at all. Now, this can be a bigger or smaller problem depending on where the outflow is, right? Because sometimes pulmonary sequestration, that tissue can have outflow that goes back to the right heart, like normal pulmonary outflow, right? And so that's when you're gonna get shunting. Guys, this is the stuff I actually know about, so if you could pay attention, that would be so sick. So if the outflow is going back to the right heart, like normal outflow, now you're gonna get shunting, right? Because you have deoxygenated blood going back to the right heart. And so that's gonna be more of a problem than if you have systemic outflow and it's just like normal systemic outflow. In that case, then the big problem is taking up too much space, and so you wanna take that out. Okay, and so then compare, well, so we already said the treatment is to remove that tissue, the CPAM, and you have to, often you'll get a CTA before doing that surgery, so you can kind of try to figure out where the, feeding vessels are. How is that different from congenital pulmonary airway malformation?
The blood supply thing.
Yeah. Yes. True. It can, I think that it can, but it can also be the same, but the big thing is that the CPAM communicates with the tracheal bronchial tree. But it's just like cystic tissue that's not effective in gas exchange, and so the treatment is still to remove it. And that will be like a higher risk removal from a, persistent pneumothorax leak standpoint, right? Because it's actually requiring you stapling across the, tracheal bronchial tree that's communicating. You are gonna have to fix it. It doesn't like go away on its own. I think that you can, actually, I don't know the answer. I'll have to look that up because I'm not sure. I would think that in terms of lung development, you'd want to get it out of there, but we take out lung all the time and people's lungs, expand to fill that space and they do well from that standpoint. So I'm actually not sure. I'll have to look up when the surgery has to happen for these. Does anyone know? Okay. And then what about, so that's congenital pulmonary airway malformation, that's CPAM, and that used to be the congenital cystic, whatever it's called. It used to be called something different, like recently, and you'll still see it on congenital cystic adenoid malformation. You'll still see some questions that has that, so that's the same as CPAM. And then what is congenital lobar emphysema? Good. So what is that gonna look like? Good. What are you gonna be confused about, especially here?
Oh, if it's.
Perfect. So it will look like and act like tension pneumothorax sometimes. And so you want to make sure you don't put a chest tube into that. And like it can cause compressive symptoms.
So. I guess they're more keyed into getting additional imaging. You know what I'm saying?
Yeah, I understand what you're saying. Right. Yeah, it would be just a different. I also think that like if they're just more alert to finding this kind of thing. That's a good question. I don't know. Yeah, CPAP and pulmonary sequestration, but I'm not sure about congenital lobar emphysema. I have to look that up.
Oh, yeah.
Would it be,
Well, it's like you're not breathing air. Oh, no, I just mean like, sort of thinking of
that's a
like,
really good question.
Yeah. Because I know they
But it
can
would be
breathe
filled
down
with
the
fluid.
throat.
I'm not sure. Yeah, that's a good point that, obviously it might be more difficult to see. I'm not sure. Okay. And then they sometimes ask about bronchogenic cysts. What's the treatment for bronchogenic cysts?
Cut it out.
Cut it out. Good. And then that I've seen that become because then they'll sometimes ask about pericardial cysts. What do you do for pericardial cysts? Exactly. So the bronchogenic cysts you take out, pericardial cysts you leave alone. Okay, great. And then I have a slide in here about the congenital diaphragmatic hernias. So what are the two different eponyms we need to know? Exactly. And where is Morgagni? Anterior. And where is Bochdolek? Yes. So they say back and to the left. It can also be on the right, but it's just way more common for it to be back and to the left. And then the anterior one will often be a little bit to the right. So I would say on the test, if you get a right-sided one, it's probably a Bochdolek, but if it, anterior posterior is really how you're supposed to think about it. Okay, and then I just have some questions. Oh, shoot, I'm missing team steps already. Let me text them. We really need to, okay, I'll send the questions out to, the people who are watching this recording later. Let me stop the recording.